Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to the AOMPT podcast. My name is Leanna Blanchard. I am excited to present today's guests coming off of a successful presentation in February at the annual APTA Combined Sections meeting in San Diego. A big welcome to Renzo Mendoza, Craig Hensley, and Jennifer Ryan. These three were members of the team presenting a session titled Chronic Pain and Hypertension, the Relationship and Evidence-Based Management. Dr. Renzo Mendoza is an orthopedic physical therapist at the University of Illinois Health System. He's served as both an adjunct instructor and guest lecturer at Northwestern University and the University of Illinois at Chicago. He received his Doctor of Physical Therapy degree from Northwestern University's Feinberg School of Medicine in 2018, and following graduation completed a one-year orthopedic physical therapy residency at the University of Michigan, Ann Arbor, and became board-certified orthopedic clinical specialist in 2020. Dr. Mendoza additionally completed Northwestern University's Fellowship in Advanced Orthopedic Practice, Research, and Education in 2022. Dr. Jennifer Marie Ryan is a board-certified cardiovascular and pulmonary clinical specialist and assistant professor at Northwestern University's Department of Physical Therapy and Human Movement Sciences. She teaches in the cardiovascular and pulmonary curriculum, physiology, and in the foundational courses of the curriculum. Her experience also includes teaching post-professional education overseeing the Critical Care Fellowship at the University of Chicago. Dr. Ryan graduated from the University of Illinois at Chicago in 1990 with a Bachelor of Science. In 2002, she received a Master of Science from Finch University, and in 2004, a Transitional Doctor of Physical Therapy degree from Rosalind Franklin University. Her clinical practice has focused on care for the critically ill individual for most of her 32 years of practice. Dr. Craig Hensley is an associate professor at the Department of Physical Therapy and Human Movement Sciences at Northwestern University. He completed his Doctor of Physical Therapy degree at the University of Illinois Chicago in 2007, his orthopedic residency at the University of Southern California in 2009, and orthopedic manual physical therapy fellowship at University of Illinois Chicago in 2011. Dr. Hensley has given over 40 peer-reviewed presentations and published over 60 articles, book chapters, and abstracts. He serves on the American Board of Physical Therapy Residency and Fellowship Education Accreditation Committee and is a Candidacy Review Council member. He is also Associate Editor for JOSPT Cases. Dr. Hensley is co-authoring the Medical Screening Clinical Practice Guidelines for the Academy of Orthopedic Physical Therapy and Federal Sections, and is working with residency directors across the country to assess outcomes in post-professionally trained physical therapists. Dr. Hensley's interests include topics in medical screening and residency and fellowship training. First of all, thank you all for joining me today.
Thanks for having us, Leanna.
Yeah, thanks so much.
Thank you.
So I would love if any or all of you could tell me a little bit about the inspiration for this project, or where did the idea for this session come from?
Yeah, I can answer that question. The inspiration of this project came about from my own reflection on clinical practice. I work at a clinic where we often serve an at-risk population with not only high incidences of chronic pain, but comorbidities such as COPD, diabetes, and again, for the purposes of this presentation, hypertension, that oftentimes are unmanaged. So it's our role as clinicians to take an account for a lot of these variables, accommodate in our interventions based on these factors, or often direct them to the appropriate providers for further management. So I spent a lot of time early in my career reflecting on my own clinical practice on how to approach these specific patient situations. Anecdotally, I started seeing a pattern of individuals of higher intensity and distributions of pain who were correlated with unmanaged comorbidities and oftentimes high blood pressure. Curiosity led me to dive into the literature on the relationship between pain and blood pressure. So it wasn't really until my fellowship training where one of our big projects was to create a lecture detailing specific pain mechanisms. Shout out to my director, who was really the one to notice the novelty of this idea and to consider evaluating and collaborating with other individuals presenting this at a conference. So this is where I reached out to two of my former professors with this specific expertise, Dr. Craig Hensley and Dr. Jen Ryan.
Awesome. It's a great background. So, and again, directed at any of you really, why is it important for physical therapists to be assessing for blood pressure or high blood pressure in our patients?
The biggest hallmark of hypertension is that it doesn't have symptoms. And so the incidence of hypertension in the US is at about 42% of the population has a degree of hypertension. That puts everyone with hypertension at risk of stroke, MI, and heart failure because of that undue strain on the vascular system. About 795,000 people per the CDC have a stroke per year in the US and 15 million across the world. About 805,000 have a myocardial infarction, according to the CDC, per year. If we as physical therapists with direct access aren't comprehensively looking at our patient from top to bottom, aren't understanding the impact that an uncontrolled blood pressure can have on an exercise response or prescription or a patient's general health, it's something we really need to step up and be good at, not just taking the measurements accurately, but interpreting those vital signs in relation to each other.
I love that answer. And to piggyback on that, what does the literature say about physical therapists assessing vitals? Are we consistently doing that? Are we good at that?
We're getting better. There was work done in 2001 from Fries et al. That showed that physical therapists who knew that their patient had a history of hypertension or a cardiovascular disease were not consistently measuring their blood pressure at outset or with progressions in exercise. Different surveys have been done. Miller et al. Did one in 2016 where they saw that things were a mite better, but still not at a threshold that meets a professional expectation. Severin did work in 2019, finding that more clinics had access to the right equipment. There were more clinics with policies setting the expectation of taking vitals, but still not matching what we were teaching in classes. And then just now in 2021, Marks et al. Did a research article that had the sad conclusion that their students were not seeing it modeled in the clinic. It's so hard as an educator to come forward with the evidence and help your students understand how they can make a great difference in patients' lives. And then they don't see that modeled in the clinic and they have a struggle about what is truly important. So yeah, the literature is saying we are getting better. The trend is moving. It's a little better than glacial, but it's not anything we should be saying we're incredibly proud of. We should be much better.
And I will speak for myself. I think that most PTs have a story of being the person that caught some aberrant vitals at a visit and having to process that. So it is unfortunate that our students aren't always seeing that modeled in the clinic.
I say to the students all the time, I say when I talk at conferences, I say, one good catch will make you a believer. But you have to know what to do with those numbers, right? Like you say, an individual finds aberrant numbers. They look at the patient, they don't see symptoms. It's very confusing. So we need to help get education out there to help therapists put those pieces together.
So you may have answered a little bit of this question already, but in your presentation, you described hypertension as a public health problem. Can you tell us a little bit more about that? Is there anything else you'd like to add to that?
It also is impacting the quality of the interventions we're imparting because it's confounding the findings we have in relation to the patient we're trying to treat if we're not taking the vital signs under consideration. So the public health is not improved because they're getting an exercise prescription that doesn't fit them. The more obvious are the points that I already raised for sure, as far as stroke and heart attack and heart failure. Heart failure alone, once you're diagnosed with heart failure, they start talking 5 years mortality risks are quite elevated. And the healthcare costs are just absurd. Medicare pays more for heart failure admissions than any other admission collectively because it is so expensive to have heart failure and it drains the system terribly. And these poor individuals need so much help. If we could find it when it's small and help them get on a regimen that actually can treat that hypertension only, it could make a huge impact on the healthcare system and on the quality of life of so many.
Thank you for that. Do you feel that we as physical therapists are equipped to be addressing this as a public health issue?
I think we have, at minimum, the tools to get people into the system so that more sensitive testing can be done. I think at minimum, we have all those touch points that other clinicians don't because we see patients over a course of time. We see patients when we're challenging them to take on exercise and having opportunity to see symptoms. If I have an outpatient come in who has no diagnosis but every risk factor, and I want them to take on an aerobic exercise program so they can get back to tennis, I need to understand how to limit their risks on on their outcomes and really improve not just their response to the exercise, but reduce their risk of untoward events.
Absolutely. So, jumping a little bit into potentially another public health problem, looking at chronic pain. In your presentation, Renzo, you shared a lot of information on the impact of chronic pain on our society. Could you summarize some of those details for us?
Yeah, as many of our listeners know, chronic pain has been recognized as pain that persists past normal healing time, hence lacks the acute warning function of physiological nociception. So, a couple different timeframes or definitions of pain, but pain is usually regarded as chronic when it lasts or reoccurs more than 3 to 6 months. So, chronic pain is a frequent condition affecting an estimated 20% of people worldwide. Additionally, symptoms have the potential to expand in the form of chronic widespread pain. This presentation, again, has a similar time frame, however, manifests either bilaterally or above and below the extremities on the axial skeleton. It's estimated that this presentation of chronic widespread pain is tended to be 10 to 15% globally. We know that chronic pain has a dramatic socioeconomic impact. So the total financial costs of pain in the United States specifically is estimated to be between 560 to 635 billion dollars. And compared to the estimates published by the NIH, the cost of persistent pain exceeds the economic cost of the six most costly major diagnoses. This not only includes cancer, diabetes, but again, for the purposes of this presentation, cardiovascular disease. We know that there's an additional increased risk of chronic pain associated with low socioeconomic status. We know that this is closely tied through manual labor jobs, lower education status, and unhealthy lifestyle factors such as tobacco, alcohol, or low physical activity. We also know that it's been proposed that several external factors may have a reciprocal or a bidirectional relationship with chronic pain. So it's important to recognize that chronic pain is a strong association with mental health conditions. Again, the prevalence of chronic pain is 2 to 4 times greater in those with these specific diagnoses. This includes major depression disorder, anxiety, post-traumatic stress disorder, and drug and alcohol abuse. It's also been proposed that sleep disturbances and pain may have a bidirectional relationship in that poor sleep during the night may worsen pain later in the day and vice versa. In addition, people with chronic musculoskeletal pain may often have other chronic diseases and long-term conditions, such as cardiovascular disease. More specifically, individuals with chronic musculoskeletal pain and cardiovascular disease experience more severe pain and disability compared to those with only chronic pain.
Thank you for that. Knowing that there is a bidirectional relationship amongst a lot of these factors, can you tell us a little bit about what the relationship between chronic pain and hypertension really is, or what are the contributing factors there?
So chronic pain has been associated with 23 to 39% risk of hypertension globally. So individuals with a history of chronic pain were significantly more likely to be taking antihypertensives compared to those with their pain-free counterparts. The relationship of hypertension and chronic pain was seen at higher levels of socioeconomic disadvantage, like I spoke of earlier. Specifically, individuals with chronic pain and socioeconomic disparities have a 10 to 12% higher adjusted odds of having hypertension. Again, going back to the topics we discussed earlier, mental health conditions have demonstrated to see this increased prevalence of hypertension and chronic pain relationship. We see that severe anxiety in individuals with chronic pain increase adjusted odds of having hypertension by close to 26%.
So, in your presentation, you also, related to this, shared some information from the literature on the difference in hemodynamic responses to painful stimuli in individuals without pain versus the same responses in individuals with chronic pain. Can you tell us a little bit more about what that difference is?
Start with just the cardiovascular and pain regulatory systems are structurally and functionally intertwined. So in healthy individuals without chronic pain, these interconnections produce blood pressure related hypoalgesia, in which a specific pain response triggers an elevated blood pressure to initiate a reduction in pain sensation. So let me give you a case example. So let's say we have a cyclist, let's name him Jesse, who unfortunately gets into an accident hitting a deep pothole at a very high velocity. Jesse calls me, tells me what has happened, and I ask him if he feels like he's injured anything. He notes initially hurting his hand at the point of the accident, however, is in such shock, he can't believe what's just happened. His heart's racing. He almost can't tell if it hurts. So the ability for us to respond rapidly and appropriately to a specific threat in the external environment is critical for our survival. So it's not surprising that we see such high complex brain systems to evolve to respond or adjust to these specific responses. So responses may be triggered either by a wide variety of stimuli, which may be unconditioned, such as this accident. So in this pain model, we see that an external stimulus, such as pain, triggered by the accident, increases the individual's blood pressure to create a reduction in pain sensation. So the proposed model of those free of chronic pain, we have this noxious stimulus that travels through the sympathetic nervous system, producing this increase in blood pressure. This increase in blood pressure triggers baroreceptor stimulation, which we know with the baroreceptor, baroreflex is leading a stimulus within the central nervous system. So this reinforces descending modulation, or in other words, pain inhibition at the painful site. So we know that there is anecdotal evidence demonstrating pain modulation primarily in the form of endogenous noradrenergic pathways or through norepinephrine. There's also been other models postulated to manifest in other pathways such as endogenous opioids. Now we have the model proposed for those with chronic pain. So those with chronic pain have known to have an association with a reduced magnitude of blood pressure related hypoalgesia, suggesting that we have possible related impairments in the cardiovascular regulatory system, potentially relevant to comorbid cardiovascular disease and risk in chronic pain. There are several theoretical interplaying mechanisms that have been hypothesized to help explain these alterations in the relationship. As pain persists, we could have possible exhaustion or reduced production of the neurotransmitter norepinephrine, which is received at the specific spinal level, as well as with this reduction in norepinephrine, we see a reduction in the receptors located at the spinal level. We have changes or a promotion in facilitatory mechanisms where instead of norepinephrine inhibiting pain, it begins to shift to promote more pain. So this is primarily associated with a shift in receptor type. So instead of alpha-2 adrenergic receptors, which inhibit pain, we have alpha-1 adrenergic receptors, which start to promote pain. We also have changes in baroreceptor sensitivity. So baroreceptor sensitivity is defined as the relationship between the change in arterial pressure and the associated interbeat interval. So this has been described as a measure to determine baroreceptor function and sympathetic efficiency. So changes in this sensitivity may occur due to altered threshold in the firing within the system. So with these changes, the activation of the baroreceptor reflex, we start to see an inability for our body to not reach the central nervous system, which influences pain inhibition. So we know that reduced baroreceptor sensitivity has been observed in several chronic diseases and health conditions, such as hypertension, diabetes, chronic smokers, and obesity. We see this change or decrease in baroreceptor sensitivity associated with increased anxiety levels. And there's also evidence to suggest that chronic pain is linked to reductions in baroreceptor sensitivity changes. This has been shown in chronic low back pain. This has been shown in rheumatoid arthritis, fibromyalgia, temporal mandibular disorders, and irritable bowel syndrome.
Thank you for that detailed explanation. So how does the understanding of the difference in those hemodynamic responses and the theories behind these changes to painful stimuli, how does this impact physical therapist practice?
Anecdotally, when we take this process, we see that certain individuals have the potential to create these hypoalgesic responses and painful stimulus. So we can do this through the sympathetic nervous system, whether it be proxy painful stimulus that we receive through manual therapy or exercise, which a stressor inherently creates this sympathetic response. However, if you tie these variables such as cardiovascular disease, hypertension, we could potentially have limited effects based off these presentations. So, it's important to understand that although this model seems very logical, its understanding has been slow to emerge due to the complexity of the autonomic anatomy and physiology. So not only are we seeing these acute fight or flight responses within the cardiovascular system, but we see it in other vital organs and peripheral regions of the body. So we just got to be careful how we interpret these changes and these findings, because at this point, it's really only been studied in the laboratory setting.
That is incredibly important to remember. The clinical application of some of these theories and mechanisms may not quite be there just yet. So I would love to talk a little bit about how we might then use these things clinically when possible. Craig, what are some of the screening tools that physical therapists should be considering and performing in patients with chronic pain and hypertension?
As Renzo touched on, there's common denominators behind both hypertension and chronic pain. So there's some common risk factors like obesity. We should be screening their BMI, depression. We can use the Hooley questions, anxiety. We have the general anxiety disorder 2, the GAD-2, screening for post-traumatic stress disorder. For diabetes, we can't necessarily screen with the lab values of glucose and HbA1c. But if someone is obese and between the ages of 35 and 70, they should be screened for those lab values every 3 years. So we should be aware of that. Substance abuse like alcohol, smoking, substance involvement screening test, physical activity. Renzo touched on sleep. There's the Pittsburgh Sleep Quality Index that we can get valuable information from. Social determinants of health screening tool, and fear avoidance. We should be screening for these. Our patients are coming in with pain, they're probably taking some type of pain medication. With certain pain medications, they have been shown to have an increased risk in elevating blood pressure. So, for example, particularly in older individuals, anti-inflammatories can raise both your systolic and diastolic blood pressure. Serotonin norepinephrine reuptake inhibitors like Cymbalta or Effexor can raise your blood pressure. And then finally, the tricyclic antidepressants like amitriptyline, that's been shown to increase your risk for hypertension.
So then moving beyond some of our screening tools and examination tools, what can we then include in our objective examination of patients with hypertension and chronic pain?
Well, I think above all else, as we've alluded to, taking vitals at the initial encounter, taking vitals while the patient is exercising, and taking vitals after the patient is exercising. And we can get into that a little bit more as we move along here. Because we think pain is driving the risk for high blood pressure, we could also be looking at some pain-specific measures. We could be looking for allodynia. We could be looking for hyperalgesia. If you have the tools in your clinic, you could be examining for pain pressure thresholds. And if there's data out there that shows that if patients are below certain criteria, they're less likely to improve over time.
And so for some of those measures of things like allodynia, hyperalgesia, for therapists that maybe don't have the necessary equipment in their clinics or are maybe not very familiar with identifying different pain mechanisms or different pain behaviors, where would you recommend that someone start if they were interested in looking at this more regularly?
Well, I think there's some really good work out there that's been published recently. There was a nice commentary put out in PTJ in 2018 by Ruth Shemeni. They do a really nice job of breaking down the different pain mechanisms in terms of nociplastic pain, neuropathic pain, and nociceptive pain. They go into a detailed description of how to further examine and manage a patient based on the most likely pain mechanism that the patient is fitting into.
I will second that as a great paper, and I refer to it often. When we then start to think about the fact that we've started seeing these patients in our clinic, we've done our evaluation and identified that yes, chronic pain is a problem here, hypertension is also a problem here. What are the interventions that we can offer these patients? And then within these interventions, are there specific guidelines that exist for how to provide those interventions?
I think the first thing that we can do that we often overlook is just having a discussion and a look over the patient's pain medications. We can ask them, are these medications working for you? If they're not, perhaps we just need to have a discussion with the patient and the physician about changing their pain medication, in particular, those that potentially can drive up blood pressure. I think another thing that's often overlooked is just discussing the importance of sleep. I think we do a good job of having that conversation regarding physical activity, but other things like sleep often get overlooked. And as Renzo alluded to, sleep can have a major impact on someone's pain and blood pressure. And I think we all know the evidence behind exercise. So there's plenty of evidence to suggest that cardiovascular exercise can have a positive effect on patients with chronic pain and also with hypertension. So not only cardiovascular exercise, but we should also be, if the patient is appropriate, to add resistance training. There's the potential for teaching someone about breathing techniques and educating patients on meditating. There's research that meditation can have a positive effect on both blood pressure and chronic pain. And then finally, I've played around with this a little bit in the clinic with some success and perhaps some not so much success. But because we think pain is the driver of this high blood pressure, we treat the pain. And what better way for us to, as physical therapists, to treat pain with our hands and manual therapy techniques. I think if we can get patients to start feeling better, hopefully their blood pressure will reduce.
It's a really great example of that bidirectional relationship there.
I think the other thing about the hypertension piece is there's great information out there about what defines hypertension, how high is too high. And no doubt it doesn't mean that there's going to be a catastrophic event in the moment. So do not send the person away if their pressure is high, if you have opportunity, like Craig said, to maybe manage that blood pressure in a way that is going to keep the patient safe and maybe make them even safer yet. But also remember that measure, even if you follow all the criteria that the AMA has worked so hard to get the word out across the nation about accurate techniques to employ when you're measuring a blood pressure, it's still a moment in time. It's still just one measure. And we all of our blood pressures fluctuate throughout the course of the day. So yes, it needs to be measured by the physical therapist, but it also probably needs a follow-up phone call if you're seeing that there's a persistent high pressure throughout the course of your session. They need to be referred to have that diagnosed and understood if they didn't know they had hypertension. They need to have the conversation about, do they have access to the medications and the other resources that are being prescribed for them to manage their hypertension? Do they have the health awareness to understand why those are so important? There's a lot of pieces that play into the PT's decision making in the moment. And so what I always fear is that people are getting undertreated. So I want people to have opportunity to think about what's a good decision making process to employ to best serve this patient, to manage their pain, and not put them at greater risk in relation to their hypertension.
Thank you for that. That's a great point. And so if we move forward into hopefully not undertreating these patients and giving them the interventions that we feel are most appropriate for them, if we move in the direction of exercise, for example, how can we as physical therapists best approach that or most safely approach that in a way that, as Jen said, is not putting them at risk, but also not undertreating them?
Yeah, I think, again, to kind of piggyback on what Jen was saying, just make sure we're taking vitals at the beginning, but know that that's not the end all be all, because it's just one measurement. But sometimes, you might take it in the office at baseline and it seems to be relatively normal, but then you have the patient start submaximally exercising. It's about 60-70% of their maximum heart rate, and that could be a tool in and of itself to screen for high blood pressure. So for instance, if I'm doing submaximal exercise and patient's systolic blood pressure is 160 millimeters of mercury or above, that's a problem. So that's another discussion that we might need to have with the referring provider, the primary care physician, whoever's managing patient's blood pressure medication. Also, we should be measuring vitals after exercise. Within 6 minutes, it should be returning pretty close to baseline. Flip side, if it's greater than 20 millimeters of mercury from baseline, or if the systolic blood pressure is above 195 millimeters of mercury at 2 minutes, these are also significant risk factors for having a myocardial event within a year. We should make sure that you're screening or examining the patient for those problems.
Thank you for that. As you presented this in San Diego, what was your main takeaway from working on this together and presenting this session? Maybe what was the main thing that has stuck with you through your work on this, or something that you really hope that attendees took away from this?
I think as Renzo was throwing out all these big words, there's a complex relationship between chronic pain and hypertension. And we as physical therapists, when caring for individuals with chronic pain and hypertension, we should be attempting to decipher the predominant pain mechanism that's contributing to the patient's pain, so we're treating to that pain mechanism. We should be screening for contributing factors to chronic pain and hypertension, like, for instance, sleep deprivation. Take vitals before, during, and after exercise. And then I think finally we have to consider both, when we're prescribing exercise, we have to consider the patient history, the beliefs, the coping skills, and our findings. And one other last caveat that I'll say is, if we think someone is having or fits into the predominant nociplastic pain bucket, they're having widespread pain, we should consider starting our interventions at non-painful sites and or aerobic exercise.
And then with that, are there any particular resources that you'd like to point listeners to?
At least in the relationship realm, Bruhl's interaction between cardiovascular and pain regulatory systems, published in 2004, that's one of the big articles that we base this presentation off of, as well as Craig mentioned the Schmenti article, The Mechanisms-Based Approach to Physical Therapy Management.
The National Institutes of Health funded what they termed the Joint National Congress. They did 7 joint national congresses that concluded in what are definitions of hypertension, pre-hypertension, et cetera, that was used internationally. They convened the Joint National Congress 8, and so much more information came forward on better understanding hypertension, better understanding all the confounding variables that impact a person's risk of hypertension, that they couldn't come to a conclusion. And yet they needed an updated resource. So the American Heart Association and the American College of Cardiology had a subset of individuals who were members of that Joint National Congress who did put together the numbers that we presently use to determine our definitions of an individual at risk of hypertension, an individual who has stated hypertension. So the lead authors are Bakris and Ali, and that was from out of 2019, out of the Journal of American College of Cardiology. And it's taken under consideration international participants as well as, published here out of the US. But such an important step to help people better understand. But just hearing the story of how they couldn't come to a conclusion tells the story tremendously to me.
Thank you for those resources. We will hopefully link to anything that you're able to provide us in the show notes. And then, so to close out, what future work do you think needs to be done in this area, whether it's clinically or in identifying these mechanisms in human populations? What do we need to do to better serve this population?
I think just from hypertension perspective, we think there's a certain population. Obviously hypertension has a lot of potential drivers, but there's a certain population that we think where pain is the main driver of that hypertension, and identifying who those patients are so we can manage them appropriately would be something that I would like to see done.
I think piggybacking off of Craig, this kind of entails more of understanding more laboratory studies on the relationship with vitals and pain, as well as like population studies. I can't get the article at the tip of my tongue right now, but I know it's a Canadian study that evaluated emergency room visits. However, these population studies didn't really account for the differences. If this is acute pain, individuals who are going to the emergency room are probably going for a more ambulatory situation, but who has had a history of chronic pain and who hasn't, and understanding if there is a relationship in vitals and pain. The other thing that we as a group talked about before is the medical management and medication of both pain and hypertension, and how do we approach either weaning patients off, or if this is our decision to work with patients collaboratively as well with the physicians about how do we wean off these specific medications based off our management, and how that interplay plays a difference between your pain responses and your vital responses.
I think it would be fantastic to have a contingent of clinicians gathering data on vital sign responses to pain management interventions, just to see is there a trend of manual therapy interventions that we can glean from gathering data over a larger N of practitioners, because that could really inform us of what more strategic steps we need to go and take when it becomes like RCT level study research.
Absolutely. All great ideas that I hope we see come to fruition in the future. Any last thoughts from anyone?
Please take vitals. Please take vitals. If you're unsure of how to interpret them, there are resources that the APTA Cardiovascular and Pulmonary has published that are freely available on YouTube. There are resources through the American Medical Association. They have nice infographics on how to limit the threats to your measurement to take an accurate pressure. No vital sign stands alone, so please always look at a pulse rate in relation to it. It'll tell you volumes. I will get off the soapbox. Thank you.
I appreciated your soapbox. Thanks for sharing it. Thank you all again for joining me today, and we look forward to seeing big things from all of you in the future.
Thanks so very much.
Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.